Hi, my name is Chloe Hoklanis and you're watching the video on the Prism fusion range. Now, so far we've talked about the 20-diopter Prism reflex test and the 4-diopter Prism reflex test. And both those tests are utilising motor fusion as an indicator as to whether the patient has binocular functions in relation to the 20-diopter, or for the 4-diopter we're actually specifically looking at whether a patient has a microstrabismus. But what we're asking the patient to do is maintain binocular single vision by making a vergence movement. By putting that base out prism, we're requiring the patient to make a fusional convergence movement to maintain binocular single vision. But we're doing that with a single prism and we're requiring a single vergence movement for the maintenance of BSV. Now we can do the same with a base in prism. If we put a base in prism, we'll require the patient to make a fusional divergence movement. And we can do this with a 4-diopter prism reflex test. If we suspect that the patient has an exodeviation, then we put a 4-diopter base in. For the prism reflex test, for the 20-diopter prism reflex test, we don't do divergence because the divergence range, as we'll see in this video here, isn't large enough to allow the patient to overcome a 20-diopter base in. Okay, but what we want to do with the prism fusion range is not use a single prism and request the patient to make a single motor fusion response. We want to gather some information about the strength of the motor fusion. And to do this, we need to measure the amplitude of the fusion range. And so what we're going to see is what is the capacity, how much convergence, how much fusional convergence can the patient make and maintain single vision? How much can the patient diverge their eyes and still maintain single vision? This gives us the strength. It doesn't just tell us, yes, the patient has binocular functions because they can overcome the 20-diopter, or yes, the patient doesn't have a microtropia with the 4-diopter. This is telling us about the strength of this fusion range, of the motor fusion of this patient. Now, there are various components of the fusion range we can measure. We can measure fusional convergence, in which case we use a base out prism. We can measure fusional divergence, which you use a base in prism. And we can measure the vertical amplitude by using base down and base up prisms. Now, to perform this, we'll use a prism bar, as we see over here to the right, and we'll ask the patient to look at an accommodative target. Now, for both the 20-diopter and the 4-diopter prism reflex test, you will use a target. It's not as important to use a accommodative target in that test, but it is important that you use an accommodative target for the PFR. Now, generally the prism reflex test we perform at near, but for the prism fusion range, we can perform that at near and far, and there are instances where one distance will be of particular interest to you than another. And what I mean by this is when you have patients who have issues in terms of controlling a deviation, then you want to have information about their fusion range at the distance where they have issues with control. So say, for instance, at near I have an exophoria with rapid recovery. That means I have an exodeviation with good control. So I'm expecting the fusion range is probably going to be okay-ish at that distance. But if in the distance it's an exophoria that breaks down to an exotropia, I've got an issue there about control. So the patient is binocular but at times breaks down to an intermittent manifest deviation. And at that distance, I'm really interested in the fusion range at that distance. And the reason I'm really interested in it is because it'll give me an indication of the strength of binocular functions and if this is a contributing factor to why the patient can't control the deviation at that distance. And then it will also give me an opportunity to look at whether treatment of the fusion range would be an option in managing this patient's problem. We'll come back to treatment options later, but you need to assess that fusion range to see if it is contributing to why a patient has issues in controlling a deviation. Okay, how do we perform the test? Well, we need a prism bar. We never do this with single prisms. And the reason is because we systematically move through every single prism. Now, as compared to the prism cover test where you can just select a prism anywhere along the prism that correlates to the estimation of the size of the deviation, with the PFR, because we're systematically increasing the demand on the vergence system, we need to start at the very first prism. So we will start at the top and move through every single prism and ask the patient to make a vergence movement. And each prism we go to is demanding more of them. So you'll start at 1 diopter, which will require 1 diopter's worth of fusional divergence. Then we'll go to 2, which means I need an extra 1. Then we'll go to 5, which means I need an extra 3, and so on and so forth. And what you'll see is as you increase the prism bar, as you lift the prism bar, you'll see at what point does this patient no longer have the capacity to maintain BSV. Okay, so what we're going to look for is 2 things, a break point and a recovery point. What's the break point? The break point is the point in time where the patient can no longer maintain binocular single vision. Let's say here we have, I believe it's a base-in because I can just see the base there, a base-in prism of 8 diopters. Let's say, as an example, that at 6 the patient makes a fusional movement and at 8 they break. They're no longer able to maintain binocular single vision. What do you think the patient will experience? At the break point, generally most, but not all, patients will experience diplopia because all of a sudden they've broken. They're no longer able to make a fusional movement to maintain binocular single vision, or in this instance with a base-in prism, a fusional divergence movement. So one thing you want to ask your patient when you're doing the prism fusion range is, tell me when you first see 2. But just as I said a moment ago, not all patients are going to be able to subjectively tell you that they see diplopia. And generally these patients have or experience suppression at the break point. So they don't notice the diplopia. So you don't have the opportunity to use a subjective response in that instance as an indicator that there's been a break. So what you'll do is watch the eyes as they diverge. So what you'll do is you'll start off with 1 and you'll see a fusional divergence movement. And you'll keep going till you see a break. And in this instance, what you'll actually see is the patient is no longer able to maintain single vision. And you actually usually see the eye break away from the usual movement that you're seeing. And often they'll flick between looking at one image or the other if they have double vision. But you'll clearly see that the eye is no longer able to maintain binocular single vision. Now, divergence is a little bit harder to observe than convergence. Okay, so that second point there around subjective versus objective measurements, we're talking about subjectively, one is getting the response from the patient as to whether they have diplopia, and objectively is telling us about you observing the eyes and finding the break point through noticing that they can no longer make that fusional vergence movement. Now, because the patient is not always reliable, particularly if they're younger, and or if they have a suppression response at break, the objective measurement is the gold standard. That is what you should take. So if, for instance, a patient tells you that they saw diplopia here at 10, but you clearly saw a break at 8, 8 is the break point. It is not. You can't take the patient's observation of it if you're confident in what you saw. Okay, so the break point is the point at which the patient can no longer make a fusional convergence, divergence response, etc. Let's say 8 is the break point. So 6 is the last point in which they made a fusional divergence movement, and 8 they've broken, they see diplopia, and you notice that they can no longer make this fusional divergence movement. What you'll now do is reverse and you'll go back to 6, back up here, and ask the patient, can you now see 1? And what you're trying to do is measure how long after break now in the reverse position, in the reverse direction, does it take for a patient to regain BSV. So you'll go to 6 and ask, is it 1? Go to 4, is it 1? And you'll keep going until the patient says they now see 1. Generally speaking, patients should regain binocular single vision 1 or 2 prisms down from where they broke. If they can't regain until the 4th or 5th prism, there's an issue there around the strength of their binocular functions. And that's why recovery is important. It's about when a patient becomes manifest, when a patient is broken, how easily can they bring their eyes back into alignment. And it's giving you that indication there about the strength of the binocular functions in that regard. Okay, so to reiterate, you start at 1, you raise the prism bar till the patient can no longer make the fusion or vergence movement, and then you go back in the other direction to see when they'll regain binocular single vision. Now, there is one more thing you can ask about, and that is blur. What we're asking here is, as we increase the prism, we want to know the first point in time where the accommodative target that the patient is looking at is now blurred. What are you measuring when you're asking the patient about blur? You're measuring relative fusional vergences. So if we want to have a look at positive relative convergence, which if you remember is when we have vergence or convergence in excess of accommodation. If we want to look at that, we're looking at the maximum strength that can be fused with a base out prism whilst maintaining a clear image. So now we're not interested in the maximum strength of prism that can maintain binocular single vision, but rather the maximum strength that can be fused whilst maintaining a clear image. So for negative relative fusional convergence, which is the opposite, it's when we have vergence or convergence less than the accommodation or accommodation in excess of convergence, then there what we're interested in is using the base in prism and seeing how much base in prism can they fuse whilst maintaining clear vision. And so with relative fusional vergences, all we're interested in is the horizontal. We're not really interested in vertical here. We're interested in this base in, base out. So how much vergence can they undertake until it affects their vision or visual acuity? Okay, so we have 3 components we can look at. We can look at the break, we can look at recovery, and we can look at blur. And for break and recovery, we can utilise the subjective response, which is the patient's communication to us as to whether they see 1 of the target or 2 of the target. And objective is as we look at the eyes to see whether it's making the fusion or vergence movement. Okay, blur is separate. Blur is giving us information around relative fusional vergences. Okay, before I move on, I want to make one more note, or a couple more notes, I should say. When you're measuring a patient's fusion range, it is suggested that you measure the divergence range before you measure the convergence range. Why? The reason is that when you're assessing the fusion range, there can be a residual tone for that response that persists after you remove the prism. And because the convergence movement is stronger than the divergence movement, if convergence tone remains when you go to assess the divergence range, you'll lower the divergence range. So it is suggested that because the divergence range is not as strong, you do that first before you do convergence, because the convergence can contaminate your response later on. The other point I have there is that there is a point where your patient will start to tell you, and you'll actually see this in your pracs, where the image is getting smaller and blurrier. And we're not really concerned about that unless you're concerned about relative fusion or vergences. So unless you're interested in recording the first point at which the image gets blurred, which is fine, there is no reason to not continue the test just because the image is blurred. The patients should still be able to tell you whether there's a single image or two images. Now, this is a complaint that usually occurs with base out prisms when you're asking a patient to converge. And the reason they complain about this is, you know that with convergence, we have accommodation. Remember that near triad? We have convergence, accommodation, and pupil constriction. So you're asking this patient to continually make this fusion or convergence movement whilst looking at a target at 1/3 of a metre. Now, in doing so, as the patient converges, they'll accommodate. And so at some point, the image that they're looking at is going to become blurred, which is the point where you've met the limits of their relative fusion or vergences. But when you're measuring fusion range, you're not concerned about the point at which the image becomes blurred. You're concerned about binocular single vision, which is, do they see one or do they see two? I'm concerned about the point at which they see or they break and they see two images. So you push through blur and you just ask the patient about when do you see two, or you observe the patient's break in terms of vergence. So when the patient tells you, oh, I think it's blurry, just encourage them, that's okay. Just tell me when you see two. A note that I don't have here, but I do want to mention is, when do you measure horizontal and when do you measure verticals, or do you measure everything every time you see the patient? No. Generally speaking, if you've got a horizontal deviation, such as an exophoria or an esophoria, or an intermittent XT or intermittent ET, you're interested in the horizontal fusion range because your issue is horizontal. So it's when you have a vertical problem, so when you have a ET with a right on left, now I'm interested in the vertical fusion range. So you're going to have to be selective as to what you really want to look at, whether it's horizontal and vertical. And you'll find most clinicians, when you go on clinical placement, won't do all base out, base in, base up, base down. They're going to look at what they're interested in. So where there's a horizontal deviation, they'll look at the horizontal fusion range, and where there's a vertical, it's likely that there's a horizontal present, so you'll probably end up doing horizontal and vertical in that instance. What we haven't mentioned here is you can do cyclofusional vergence, which is looking at how much can I excyclotort the eye and maintain single vision, how much can I incyclotort the eye and maintain single vision. Prisms cannot tell us any information of this. Prisms are unable to give us any information around torsion. Okay, the best test for this is the synoptophore, if we want to look at cyclofusion, which we'll talk about later. So here, all we're looking at is horizontal and vertical, no capacity to look at cyclofusion. All right, let's go over what should we expect a patient's fusional amplitudes to be. So the fusional amplitudes expected is different depending on what you're looking at. If you're looking at fusional convergence versus fusional divergence, whether you're looking at near or distance, and whether you're looking at vertical. The greatest capacity for the horizontal fusion range is at near. So at near, we expect that a patient can make a fusional divergence movement of about 15 prism diopters. In the distance, we expect about 35 to 40. These are averages, they're normal. So not every patient will fall within this. I mean, some of you, when you get into the prac room, will find that you get to the 45 and to the end of the prism bar and you still maintain binocular single vision, which means you're above 45 prism diopters. So these are mean averages of what we expect of our patients. In the distance, we see the numbers almost half. So about 5 to 7 degrees of fusional divergence and 15 prism diopters of base out. And for vertical, irrespective of whether it's near or far, we get about 3 base out, 3 base down. So we get about 3 diopters of vertical movement either way. Now, why do we need to know these normal figures? Well, it gives us an indication of whether there is an issue with our patient's fusional amplitudes. But when we're looking at fusional amplitudes, we need to concentrate on the fusional divergence movement that relates back to the patient's issue, or back to the cover test result. So let's say, as an example, we have a patient who has a ESO deviation and they're struggling to control that ESO deviation at near. Intermittently becomes manifest at near, or they have slow recovery at near of the esophoria. What does it take for a patient to control that ESO deviation? They need good fusional divergence. So when I perform the Prism fusion range, you should always perform both directions, both the fusional divergence and convergence. You shouldn't just do one. But I'm particularly interested in that fusional divergence. Is it normal? So my expectation is that it will be about 15 diopters base in. Say you find it's 2 diopters base in. Well, now you know you've got an issue, it's very reduced. And now we have an identified issue that we may be able to treat. Now, before we conclude this video and talk about recording, I want to make one more distinction. The distinction between fusional reserves and fusional amplitude. Now, to understand this, we need to understand what's happening when a patient is controlling a latent deviation or a heterophoria. Let's look at this example of a patient who's 20 years of age and has an intermittent exotropia. So sometimes they're exophoric and most of the time they're exophoric. Sometimes they break down to an exotropia in the distance. And the PCT has been performed at this distance and it's been found that the patient has 22 diopters of base in, or the size of the deviation is 22 diopters. This means that when the patient is exophoric, they are controlling 22 diopters of exophoria or of an exodeviation. Now, to control 22 diopters of an exodeviation, they need to be utilising 22 diopters of fusional convergence. Okay, because the eyes are drifting out, we need convergence to bring them back in. So, when we commence the Prism fusion range, you can only do so when the patient is bifoveal, which means that they're in an exophoric state. If the patient has an exotropia at the commencement of the Prism fusion range, they'll be unable to do it because you're looking at how much vergence movement can I undertake whilst maintaining binocular single vision. And when they're exotropic, they don't have binocular single vision. So you're relying on your patient being straight at the commencement of the fusion range because you need them bifoveal and to have binocular single vision to begin with, and then you need to extend them and push them and see how much vergence movement can I get, how much fusional vergence can they push through and still maintain binocular single vision. So this patient at the commencement of the Prism fusion range would have an exophoria of 22 diopters that they're controlling with 22 diopters worth of fusional convergence. So the reality is that when you introduce that first prism of 1 diopters, you're not starting at a baseline of orthophoria. You're starting at a point where they've already utilised 22 diopters worth of fusional convergence. And so what we found in this patient is a Prism fusion range of 26 diopters base in and 8 diopters base out. Now, this looks rather odd if you look at normals. Let's take a look at our normals. If we go back here, what we're expecting in the distance is 5 to 7 and 15. And our previous example had 26 diopters of base in and was at 8 diopters base out. So it's saying that fusional divergence exceeds normal and base out is very low. That's not the case. The actual amplitude is not 26 base in and 8 diopters base out. These are our reserves. What do we have extra to what we're already controlling? So this patient is controlling 22, and on top of that, this is what they have, and these are called reserves, or fusional reserves. If you want to actually calculate the amplitude, you need to consider what they're already controlling. So they're using 22 Prism diopters of fusional convergence. So when we introduce the base out Prism, we have found that the patient can do an additional 8 diopters of fusional convergence on top of the 22 they've already done. So really, we have found that the patient has 30 diopters worth of fusional convergence, not 8 diopters. They already did 22 to overcome the exophoria, and when we introduced the Prism, they did an additional 8. So they've actually got 30 diopters. That's their amplitude. 8 is what they have in reserve. 30 is the actual amplitude. Okay, how do we work out the first component? The patient's already done 22 diopters worth of fusional convergence. So in order to measure fusional divergence, we need this eye to get back to 0, back to ortho position, and then start to move the eye into the fusional divergence. So 26 has to be subtracted from 22. So we've got to go 22 outwards towards 0. And then, once we've reached that 0 point, the patient's only made 4 diopters of fusional divergence movement. And that is actually what represents the amplitude. 4 diopters of base in. So in terms of the amplitude, it's actually 4 diopters of fusional divergence to 30 diopters of fusional convergence. And so we see that this is relatively normal. This should be about 5 and this should be about 15. Actually, this is far more or exceeds normal. So there is no issue here with the amplitude. Whereas if you only looked at the reserves here, you would have assumed that possibly there was an issue with fusional convergence. And this is particularly an issue where you have significant phorias being controlled. If you have a small exophoria of 2 diopters or so, isn't going to impact that much on the amplitude when you do your subtraction and addition. But certainly with a 22 diopter exo, you've got to consider that as part of your analysis of whether the amplitude is reduced. Now you just got a taste of recording the Prism fusion range, but I'll talk you through this now. So here we have the PFR for Prism fusion range, we have with correction, and we have the distance at which it was performed. And what you should record is the break, which is the point in time where the patient can no longer maintain binocular single vision, and here the recovery where the patient regains binocular single vision. And the minus indicates you're assessing fusional divergence. And then we use an arrow as an indicator of range. And we move into fusional convergence with the plus, the break, and the recovery. And here is an indication of whether the patient experienced diplopia on break. As it is suggested that if a patient breaks down into suppression during the Prism fusion response or when they break, this is an indicator that they may be having issues with control. Now, for clinicians who don't measure recovery, and I don't encourage you not to measure recovery, it's a few seconds more, and it is best to be able to get an indication of how quickly a patient can regain their binocular single vision. But if they don't measure recovery, all you'll see is the break point. So here we have 8 to 20 with diplopia indicating what occurred at break and whether diplopia was experienced in that at that distance. Okay, that brings us to the conclusion of this video. Thank you for watching.